Welcome to the Reverse Mullet Healthcare Podcast from BP2 Health. Today we are talking with Colby Schaefer, founding partner of Incline Actuarial Group, about how the great unwinding of Medicaid triggered by recent regulatory changes is affecting real change in healthcare, but perhaps in the wrong direction. But first, who are we? Why are we here? Why did we name our show the Reverse Mullet Healthcare Podcast?
We want to be relevant, informative, and creative, but we also want to be entertaining and have fun. So it's party in the front, business in the back. Like a mullet, only reversed.
We are your hosts, Justin Politti, Ellen Brown, and Dave Pavlik remotely. We are passionate, innovative, and collaborative, and are committed to solving our industry's most important issues together with our clients. We have a combined 90 years experience.
Which just makes us sound so old. In each episode, we will dig into a hot healthcare topic and dig into each other.
Be gentle on me.
Never.
No chance. No chance. You're like my sibling rivalry here. Sibling rivalry we have. You're going down.
So today, as mentioned, we're talking to Colby Schaefer, founding partner of Incline Actuarial Group. We get the pleasure of working with Colby and team all the time. Colby's an actuary with more than 15 years experience, where he has specialized in Medicaid capitation rate development, value-based care, healthcare reform modeling, and designing analytics solutions. Before founding Incline, Colby most recently served as chief actuary of Arizona's Medicaid agency and spent a decade in actuarial consulting focused on Medicaid and risk-bearing organizations prior to that role. So it's safe to say Colby knows the topic we are talking about today better than most in the industry.
Which is exactly why we were lucky enough to land him on the podcast to talk about this.
But before we get into that, we're going to have a little back and forth.
Of course. What we do. It's our party in the front.
And I'm really interested to hear about all the ballparks that Colby has visited, Major League Baseball parks. And I'm hoping his favorite is somewhere in New England.
So you visited all of them?
So fun fact, I have visited every stadium, but the Rangers opened a new ballpark 3 years ago, and I have not been there yet.
Oh.
Okay.
And yes, the Pirates, my hometown, it's my favorite ballpark. The team is not that great.
Ryan Stadium?
PNC.
Oh, shoot. Sorry.
Yep. Right on Three Rivers.
So a lot of road trips to accomplish that feat.
Wow.
No doubt.
Wow. And
Who's your second favorite other than your home team?
Ooh. So surprising ones, I like Cleveland, Seattle, Boston.
Fenway.
I love Boston, but Wrigley did not have the same feel to me.
Really? I just love these
Wrigleyville's a lot of fun, though.
Yeah, well, Wrigley's hasn't had all the modifications that Fenway's had.
Oh.
Right? I mean.
Yeah, it's more modernized.
Yeah.
It doesn't have that old nostalgic feel as much as Fenway.
Okay. All right. So as the nutty crunchy one of the group, I share this love of traveling the world. I want to know two things. I want to hear a little bit more about your national park quests. You probably heard last week when we released the episode with Dr. Pittman that she is on a quest to visit every national park. So very much a kindred spirit with you on that one. But also you have a love of Italy, which I share, and I want to hear more. We want to hear more.
So Jerry, my founding partner at Incline, has been to even more. You know about how him and his wife and kids have traveled. But I'm over halfway there. So I love...
Jerry and I share the RV thing because I lived in an RV for a year and a half with my husband, but before kids, and Jerry has been adventurous enough to do it with kids. So...
Yeah, with 2 under 3 for quite a bit of time doing
Wow.
Yeah.
Somehow the Sprinter always works its way back to Florida, apparently.
Yeah.
This is true. Very true.
He was just leaving Florida yesterday.
Okay. Well, so anyways, keep going. Yeah. Sorry, we digressed down the Jerry path.
Yeah. So I love traveling this great country of ours. So there's plenty more to see. But the train hopping 2-week Italy trip that my wife and I went on 5 years ago was absolutely the best, and really need to go back.
Where did you go in the country?
We landed in Venice. Did a couple nights there. Went down to Siena. That was our home base in Tuscany for 3 days. Went to Rome for a couple of days. Went to a soccer game. Did all the sightseeing there. And then we went up to the Cinque Terre. Spent 3 days there, and then went up to Lake Como. Flew out of Milan. Our flight was actually delayed a whole day And Milan was just where we were flying out of. We had a blast in Milan. It was a rainy day there. We were just eating, walking around, enjoying ourselves.
Before
Can't
the
go
kids.
wrong in Italy.
That was before.
So so if I'm doing my math right, that sounds about right. So that was 5 years ago. So it seems like we met you around that time, and it seems like for a while there, pretty much every time we talked to you, there was either another baby on the way or one had just arrived. And I just loved how you shared in your when we asked you about your work accomplishments, you shared that any work accomplishments pale in comparison to being a father of 2 little girls. Must be interesting to be a dad of girls. I've got 2 boys, so more power to you.
It's adding more gray hairs as we speak, but it's all worth it.
So how old are your kids, Colby?
Daphne is 3. She just turned 3 a week ago, and Felicity is 6 months old.
Oh, those are pretty names. I like that. And I have a.
Thank you. Yeah.
I'm the only one in our group that has a girl, so I understand what it's like to be. I can't tell you what it's like to be a girl dad, but I can say with a girl
fun.
mom. But I'm on the other end of the. I'm on the other end of the shoot. My daughter's now 19, so it's kind of crazy to think back to when she was 3.
Yeah, no, he's knee deep in diapers right now.
Yeah, just knee deep in all of it. So it is quite impressive, Colby, all you're doing given your commitment to your family. And so I do have to digress to the travel piece. I highly recommend, if you like Italy, to go to Sardinia. So imagine Tuscany on the Mediterranean without the crowds that you experienced when you were there. So just throwing that out there. I don't know if I want to tell everybody in the audience that, because maybe everybody will go, but
They're good.
I was going to say I'm more interested in.
crowd.
I'm more interested in the that you're in a bowling league. What type of bowling is it? Candlepin? Is it regular? What's the
is that a duck pin? Is a candle pin a duck pin, or is that different?
duck pin's different than a candle pin.
So there's like literally 3 different.
Never heard of a candle pin.
I think
It's
I
a
want to
New
do this
England thing.
podcast
It's a
forever
New
just so I
England
can
thing.
learn all this
There's
stuff.
duck pin. I don't know candle pin.
Candlepin is a New England thing. Just sticks.
Really?
Yep. It's the same ball that you use with duck pin. So
Okay. We used to have an annual duck pin bowling tournament before kids in Baltimore. We lived in Baltimore. We used to have the annual bowling tournament, and it was nothing but debauchery. And we had one of those big 45 that was this big 45 bottle, and we would use nail polish to write the last name of whichever couple won said bowling tournament. See, I can be fun. I'm not just a dork.
So Colby, let's hear a little bit more.
Oh, it's very much a social league, but I've been proud of myself. My score has been improving. League play is actually tonight. An unconfirmed fact is that this alley was, it's one in Pittsburgh, obviously, but it's the one in Pittsburgh that had the Rose Ball on a shelf. That Rose Ball was used for the filming of Kingpin.
Yes.
So if you remember Bill Murray's
Yes.
character, Ernie McCracken, in
Yes.
that movie, that's where that ball came from.
That's awesome.
That is
Kingpin,
awesome.
One of my favorite, Munson. We
Nothing
use that
better.
term to Munson things all the time in our household. So
It's always cool when you can do something and be able to bring in a movie.
Yes.
Like the people know about. So, all right, well, let's jump into our topic, because I know we have a limited amount of time, and we could talk forever on this stuff. But our platform for the podcast is discussing things that can affect real change in healthcare. And our topic today is the great unwinding of Medicare, and it's certainly affecting.
Medicaid.
Oh man, this is a long day, I think, and it's only.
Medicare hasn't started to unwind yet.
No, it has not. Although maybe
just ramping
it's
up.
like a Freudian slip. But okay, so the great unwinding of Medicaid, and it's certainly affecting real change, but perhaps not good change. Although Colby, I think you might have a different opinion on this. We were sort of dialoguing a little bit late last night about this, but so a lot of people don't even know about this. They don't even know about this great unwinding. But I am going to quote some statistics that you recently shared on LinkedIn. As of January 16th, there have been 15 million Medicaid enrollees disenrolled. In contrast, 28.9 million had coverage renewed. That leads to a termination rate of approximately 34.1%, set approximately only as an actuary would say at 34.1%. You then went on to note that 71% of all people who were disenrolled have had coverage terminated for procedural reasons. Can you shed a little more light on this?
Yeah, and a quick background on this for the listeners. So the Medicaid disenrollments were frozen as part of the COVID-19 public health emergency, and that was a trade-off for enhanced federal funding. That provision went away April 2023, and states had to unwind these continuous coverage requirements. So trouble is, there's a 3-year backlog, and people's contact information is likely out of date, and even many state staff haven't been through eligibility redeterminations and the subsequent termination process. So it's expected that 20 million or more people will lose their Medicaid coverage during this unwinding. However, many might already have other employer-sponsored coverage. So a lot of people may intentionally not respond to these eligibility requests or miss them altogether. So for the ones who are still eligible for Medicaid, expect them to return to coverage months following their initial termination, something we call churn in Medicaid.
Which is not good.
Oh,
Churn is never a good word when it comes to members and patients.
right. But I think you mentioned you quoted some prior MacPac research on the churn. What are your thoughts on that?
Yeah, so MacPac had a phenomenal study on rates of churn with consideration for these continuous coverage provisions. And churn was about 30 to 50% for children and young adults. Now, churn doesn't necessarily mean they were always eligible when they lost coverage. A decent number of beneficiaries, especially TANF, expansion, and CHIP, they have changes in their wages. So this income variation also leads to that high churn rate that we do see in Medicaid.
Got it. That makes sense.
I think you said you were about 2/3 of the way through the entire Medicaid unwinding process. D-SNPs and companion LTSS programs are near and dear to my heart for a variety of reasons. How do you think they might be impacted?
Yeah, there's been varying opinions on this, Justin, and anecdotal evidence on dual eligibles. I think it varies state to state, depending on how much data sources via ex parte processes have been used. That's a fancy way of saying you're using some other data source to verify eligibility rather than sending a form. So there are some states where duals could be more at risk for procedural terminations in which Medicare enrollee didn't get the paperwork or didn't respond. Some states support online renewals. So as you can imagine, for an older population, there's going to be a lot of variation to this. For the most part, though, older individuals generally have stable fixed incomes, so there's less overall disenrollment expected for these populations, but still can be impacted from state to state.
Although I pale in comparison, I am also a fellow data geek. And I want to hear more about your work with the Society of Actuaries on modeling the great unwinding of Medicaid. Anytime you get to work with a fancy name like that, with a fancy group like that, it's super impressive. And especially I want you to tell us what a durational triangle is and how it was used in this work. But first, I have to tell you that I have a tenure as an actuary. I think we talked about this, but I'm not sure. But I took one actuarial exam. I worked as a quote unquote actuary after being so I was an underwriter first, and then I moved into actuarial. And two things happened that told me that was not the path for me. So first, before I took the exam, we did the Myers-Briggs. You guys know the Myers-Briggs, right? So, and this was back in the day when HR wasn't a little bit frightened of what the Myers-Briggs might actually do or culture. So the HR people came in and we did the big Myers-Briggs thing. And you can kind of imagine, if you know me or maybe even if you listen to the podcast, I'm definitely not introverted, right? I'm extrovert all the way. So they had us do, it was the funniest exercise. They had us all do it. And then we had to look at each attribute, right? Each of the 4 letters. And then we had to, this is where HR has changed. They had us line up on the wall of the conference room in order of where we were on the spectrum of our letter. Okay. So imagine a room of 12 people, 11 people standing on this side of the wall, and every single time Ellen standing on that side of the wall. And I was like, I feel like maybe the universe is sending me a message here. So that was sign number 1. And then sign number 2 was taking the actuarial exam. And I was like, nope, not for me. I don't need to do this for the next 10 years. I did pass the exam, but I was done. I was done. I was like, that's the end of that. And then I was able, I purposely moved into another opportunity, and that was another story for another day. But anyway, so getting back to the topic, can you tell us about the model that you were part of, and then also the durational triangle, or in whichever order you care to disclose?
Well, yeah. And first off, Ellen, I'm the extroverted actuary, and I failed exams more than I passed them. My first score on my first exam ever, I got a 0. And I'm old enough that it wasn't, the grading came in through like a postcard, and it comes in like 2.5 months later. I called SOA customer service and it said, there has to be some problem here. I got one question right, didn't I? I had no clue about how the grading curve worked or any of that. So
that's outstanding.
So
you're basically telling me if I had persisted, perhaps I would have done okay, but I gave up too early. We did actually. We were just telling the team in here that does the recording for us. We were saying that you're sort of like the opposite of the actuary, the non-actuary. You're the actuary intellectually and professionally, but personality-wise, you are not. So there you go. You just backed it up by saying you're an extroverted actuary. So
no, there's some of us. So. On the model, so we made this model for the Society of Actuaries. It's very input driven. So the hope is that it saves actuaries, CFOs, and the like a lot of work. It's able to handle like 9 different populations that you can plug in there. It can use the state Medicaid and CHIP data that we have from CMS. It can override it with your own enrollment data. So think it from a plan perspective, a risk-bearing provider, right, or any other type of entity. So they can put their own enrollment data there, apply assumptions on changing risk patterns by duration of enrollment. And we can obviously, see, given the Medicaid churn patterns that we discussed, it causes varying level of demand based on month of enrollment. So this model controls for that on top of population growth, movement between cohorts, and it simulates results of a low, mid, and high enrollment scenario. So it's been a helpful tool, but it's very much input driven. And I love that you mentioned durational triangle, because I think it is a term that I created last year when working on this model.
Really? And what
Wow.
meaning? So explain what that is. You can't just like drop that and then walk away.
Yeah. So triangles typically in actuarial work usually has to do with reserving. And it's not just health insurance. It could be like any type of insurance. So it's looking at the lag of payment and when the actual claim payment happened versus when the claim incurred. So it does this incurred by pay month triangle. And you can then determine how much open risk there remains before, a month is complete.
So like another way to talk more definitively about incurred versus paid and that. So it's, not exactly, but it gives another kind of a firmer base on that elusive discussion that many.
Yeah, and instead of incurred for here, it's like really duration, the month enrollment. So if it's their first month enrollment versus their 7th month, they're going to move up through the grid, and other members, they're going to be moving over. And so it tracks them as they move that, and how their acuity potentially can be changing over the course of their enrollment.
So where can listeners find access to this model? Is it something that people can access, or do they have to become part of the Society of Actuaries?
No, it is open to use in the public. It's on the SOA's website.
Okay, cool. So there you go. A little nugget of info for some of the CFOs out there for the health plans that are trying to sort out this great unwinding.
Yeah, you just search SOA Medicaid unwinding model and you should be able to find it.
Okay, cool.
We'll put that in the show. We'll put that in the show notes once we figure out how to do show notes.
Yeah, we've tried that. We haven't been very
This is all
successful so far.
This is mostly over my head, but I think I'm one of the many people who don't fully understand the gravity of what's going on here with the unwinding. I'd imagine there would be changes in acuity due to these enrollment shifts that will ultimately impact capitation rates and budget projections. What other effects do you think we need to be worried about or thinking about?
Yeah, Dave, and like those financial actuarial considerations, that's what my profession gets focused on. But ultimately, continuity of care is a concern when you have an event like this. Mm-hmm. Care management, member engagement are critical. Healthcare navigators, whether they're at the state, plan, or even with a provider group, they're going to be helpful to ensure people, even if they lost coverage, are able to reobtain it and then not have any gaps in care. So this is something that's going to live around for a while. I mentioned churn that follows a year after the unwinding, and we're not even finished yet.
Wow. So I have a question for you. Medicaid programs are near and dear to my heart. I have my own background as to why, but I want to hear from you. Like, how did you come to have such a passion for the Medicaid line of business, and what can it offer, I'd say, for other parts of healthcare?
Yeah, so I don't have a personal driven passion. You kind of fell into it, but then realized there's so much innovation in Medicaid where so many other parts of healthcare can borrow and learn from. I remember well over a decade ago, I learned about the story of Oregon Medicaid and their CCOs. And basically with the waiver that they had with CMS, they were, long and the short of it, buying AC units for seniors, that are living in apartments. So they're not having to deal with heat stroke or then rack up costs for the ambulance and emergency visits. You can get where that's going. It's pretty obvious when you explain that as just an anecdotal story, but it improves health outcomes. It saves on claim expenditures. It's a win-win. And so to me, like thinking broadly, that ties to my thesis of risk-bearing organizations. So not even just states or health plans, but also providers. Like think of a provider group led by PCPs. They're front and center of the patient. And if they could be agents of change and better manage their population and control their finances and handle the risk, then there's certainly a lot of opportunity there.
Yeah. Our conversation the other day went even deeper when you and I were talking about a completely different thing, but we were talking about primary care clinics, right? And taking risk on and tackling what many perceive to be non-health issues, right? We were talking about this, the point that it ultimately leaves, it costs us billions of dollars for these quote unquote non-healthcare issues. And we just recorded an episode. So when you talked about innovation, it really struck me because we just recorded an episode that talked about food. And food as medicine has actually gotten the most traction in Medicaid. So it really validates your point that Medicaid can be a proving ground of innovation, but yet it's sort of like this like stepchild that we sort of put over in the corner, I mean, we don't, but we do. As an industry, it's like, oh, Medicaid. Got to solve for that, but there's not money there, but there is money. It's like, it's a scary proposition for many providers. So what do you have any further thoughts on that one?
Yeah, I mean, it's no surprise given like Medicaid generally pays less than Medicare and commercial. So from a revenue optimization standpoint, it might be prudent for some providers like physicians to control how many Medicaid visits they get. But I think this is where the power of contracting, especially value-based care rather than fee-for-service, is key. And again, I think it all starts with primary care as being that central source for managing health outcomes for the patient.
Absolutely.
Colby, we ask all of our guests this, because we really want to we're trying to affect real change in healthcare. What would your buy the world of Coke moment idea for healthcare be?
And Colby's too young for buy the world of Coke, I think. But
is he?
Well, he's certainly.
We're
like 2 decades ahead of Colby, but yeah. I feel
we're stuck in the 70s. But Colby,
I'd like to teach the world. You don't know that that commercial doesn't ring a bell.
It's like a kumbaya kind of thing. So.
Look it up afterwards.
Living in perfect harmony. Yes. Living in perfect harmony.
Yes.
Yeah, there you go.
The only Coke commercial that I know from the 70s, which does predate my birth a little bit, has to be Steelers related.
Oh yeah,
of course.
Yeah, Mean Joe Green.
Yeah, there you go.
Everybody knows that one.
Yeah. So tell us your thoughts here.
I don't.
Yeah. So healthcare is an onion. That's what I always tell people. So you'll have to bear with me a little bit on this, but my actual view, it looks at risk, how to best control it, not just for payers, but also the population. And that's the purpose of insurance, right? And in a lot of ways, American health insurance isn't quite like insurance.
Yes, yep. Exactly. I'm going to interrupt. I say this all the time when I get into conversations. People say to me on a plane, like, well, how are you going to fix healthcare? And I'm like, well, the first thing is it needs to actually be insurance, right? It's not insurance. We have sick care. So I always use the analogy of health insurance versus homeowners insurance. Like, I can't get my roof, when my roof needs to be replaced in 10 years, I don't call up and make a claim on my homeowner's insurance, right? I just have to get the roof claim. It's maintenance, and that's not. So anyway, sorry, back to you, Colby, but I couldn't agree more.
Oh yeah, and at its core, The purpose of insurance is to reduce financial uncertainty, protect against these unexpected financial losses. And that's due to infrequent situations. So, to me, there's always seemed to be this disconnect when many Americans are saddled with a bunch of Medicaid debt or medical debt, and health insurance isn't covering just catastrophic events. So it's a healthcare benefit within an insurance model, but the American consumer is completely immunized against the expense, not knowing how much doctor visits or procedures cost.
Yes, interrupt again, because I didn't know how aligned our thinking was on this until we had you on the episode, which is funny because we work together a lot. I always go back to that analogy of getting your car fixed, and you don't ever just like drop it off at the shop and say, "Oh, just send me the bill." You always want a quote first. And with healthcare, you literally cannot call the doctor's office and say, "How much is this going to cost?" They'll say, "Well, I'm sorry, you'll find that out once you do that." And then you add in the fact that employers are making all the decisions about benefits and pricing.
Too many middlemen.
Yeah, exactly. There's too many people involved. So sorry again. I interrupted again, but I get excited whenever somebody has a similar thought process.
No, I can see the level of excitement. So I think the thing about this, like consumerism, consumerism's a powerful mechanism, right? In this country. And if it was more empowered within healthcare by having some type of healthcare benefit in the form of, like, let's say a cash stipend, you have HSAs and FSAs, combined with a high deductible catastrophic health insurance, because there's emergency services that we don't have the luxury of being a decisive consumer, then I think we're getting somewhere. Going back to the primary care component, I think the PCP needs to be front and center as well and be afforded the time and have financial incentives to manage the risk appropriately, like for their panel sizes. So, risk-bearing providers, not having one patient shuffled on another and actually having time with them so they can focus on issues of access to care and housing. And Ellen, when you're mentioning food stability and behavioral health and other issues.
Yeah, no, exactly. I mean, now I'm the one getting excited.
Now you're singing his tune.
Because this is the structure that I long for, right? That we have this, this opportunity to be able to access care in a way that's the freedom to be able to interact with your provider, not worrying about this
health care.
The insurance aspect and what's covered here, there, whatever the case may be. If you knew you had a catastrophic kind of umbrella, right? And you're the one that's got to investigate and pay for the other components. To me, it's a more sustainable model.
Yeah.
I think the trend of the system is there, but it's very, very slow. We have increasing price transparency. There's these health home models and ACOs, social determinants of health being factored in. Years ago, there was this financial cliff in healthcare with the ACA and marketplace plans came in there and they took away some of that. But there's obviously a lot more work to be done to align health outcomes, affordability, and take all these inefficiencies out of the system.
Yeah, and so before we let you go, Colby, thanks for being on. Before we wrap up, I want to go back to the question we asked you about what legacy you would like to be part of in healthcare. Can you share that with everyone?
Yeah, I mean, there's a bunch of ideas, but I really think it comes down to like empowering primary care physicians through risk-bearing arrangements, enables those providers to tackle the risk of their population no matter what payer. So they're not delineating between Medicaid, Medicare, marketplace, commercial. I think that's where my heart is going. The biggest hat that I've worn as a health actuary is in Medicaid, and it has a lot of that innovation. It plays a major role in primary care and all these non-health drivers of risks. So I think it could be very applicable, bringing all those together, and me playing a role to try and spearhead that. And the other thing about that is that Medicaid's there for people from cradle to grave, and it's heavily misunderstood.
Yes, I think we definitely need to do some more episodes on Medicaid. So, well, as much as I hate to end the conversation, because it's much needed. I mean, we could spend hours talking about Medicaid, and quite frankly, I think we should spend a lot more time talking about Medicaid because it is a really important component to this industry. But we have to wrap up, so thanks again, everyone, for joining us. I'm Ellen Brown.
I'm Dave Pavlik.
And I'm Justin Politti. We are the partners at BP2 Health, your best chance for real change.
And as you can tell, we could talk all day about healthcare. Drop us a line through bp2health.com. And thank you very much, Colby, for making the time to join us today. Yeah, we really appreciate it. The Reverse Mullet podcast is produced by MMG Studios in Tampa, Florida.